My dear students, in continuation to my previous talk on the difficult to treat gram-negative infections in the ICU, this is the second series on difficult to treat gram-positive infections in the ICU. Let us start with this case, a 54-year-old post-operative ICU patient who has developed MRSA bacteremia and is persistently positive on day 1, 3, and 5. And area under curve guided vancomycin, if we drew the therapeutic drug monitoring, that is found to have a value of 520 milligram hours per liter. And it is suspected that it is due to biliary drain infection or colonized prosthetic material, and the patient does not have any major organ dysfunction yet. Now, you could imagine this scenario, because if this bacteremia goes unabated, then there is every likelihood that the patient goes into multi-organ dysfunction very soon. So how do we treat such persistent MRSA bacteremia, which persists for more than 72 hours despite being on appropriate therapy? Now, the step one in such cases is to confirm this persistence. Before escalation, you have to confirm whether the vancomycin is area under curve appropriate. And if you see that it is 520 milligram hour per liter, as per the calculations, it is seen that this is the therapeutic. So it is under the area under curve, and therefore it should work. Second, adequate source evaluation was done, because unless and until source control is adequate, especially if the patient is post-operative and there is a nidus somewhere which is amenable to drainage or amenable to be removal by exploration, the same should be done. And thirdly, to be sure that no obvious removable foci is missed, which may be other than the site of surgery, the site of drain, or the site of operation. If there is a second focus that should be removed, if it is removable, then this is particularly true in GI malignancies. We often find a separate focus other than the one for which the patient has undergone oncosurgery that can lead to bacteremia due to such situations. So the definition of persistent MRSA bacteremia is positive cultures for more than or equal to 72 hours after initiation of appropriate therapy. So once it is confirmed that it is persistence, then the second step two is to look for the immediate diagnostics. So among the diagnostics, the mandatory ones are the daily blood cultures. Until the blood cultures turn negative, the patient should be considered as positive for bacteremia. The transesophageal echo, especially even if the transthoracic echo is negative, because the sensitivity is very high with transesophageal echo, and it can pick up some focus or nidus which escapes the notice of transthoracic echo. And the search for hidden focus should continue to, particularly in this patient who has undergone abdominal surgery, biliary stent if there is any, or drain if there is any, intravascular catheter if the patient is had in the operation, if the patient is having some kind of symptoms related to the back, then vertebral osteomyelitis, or if there is any psoas abscess. So these are some of the hidden focus that goes undetected, and if they can be detected on time, probably things can revert very soon. And if it is not there, then we have to go for high yield imaging in the ICU, like CT abdomen and pelvis, and also PET CT if it is available, because this is often considered as game changer in persistent bacteremia by being in its ability to identify such focus. So never escalate antibiotics in persistent MRSA bacteremia without ensuring source control first. If it is source control is identified, the source control has to be done first. After this, the step 3 is the source control, which has a huge survival impact. So either drain removal replacement is often decisive, and one has to look for, besides the microbiological tests, one has to look into the clinical condition of the patient and the consequences thereof, whether by doing the replacement or removal the patient can is likely to deteriorate by in, or whether the patient is likely to deteriorate more if such drain is left in situ. Second is the biofilm on plastics. It is near impossible to sterilize, so same should be avoided. If a catheter, stent, or prosthesis remains, the bacteremia continues regardless of the drug, because the source is there and that intermittently keeps shedding the bacteria in the blood. So that is the reason why, if the catheter, stent, or prosthesis is there, if they are possible to remove, they should be removed. So in many post-operative cases, cultures clear within 24 to 48 hours once the offending device is removed. Now, the antibiotic escalation now is not, it should be evidence-based decision and not just a whimsical application of one's mind. If the patient was on vancomycin and the vancomycin is failing, one has to ask that what is the cause of this vancomycin failure. Usually, there are three mechanisms by which the vancomycin can fail. One is the MIC creep. Even if it is still lower than MIC is less than equal to 2, but the creep phenomenon continues. Creep phenomenon is that when serially the MIC gradually increases, and that increases because the organism becomes gradually more and more resistant to the used antimicrobials. Second is the biofilm associated tolerance. We know that not all drugs are able to penetrate the biofilm, and the presence of biofilm itself gives an additional protective layer to the microorganisms to survive. So, this biofilm associated tolerance is also a cause why the vancomycin may fail. And poor penetration into the infected material. Whether or not a biofilm has been formed, the infected material is there at a particular site. So the antibiotic should attain concentration first in the target site or the target organ, and then it should penetrate the infected material. So poor penetration also leads to failure of the vancomycin to act, because vancomycin, as we know, is not a biofilm active drug, and therefore in the presence of biofilm, its efficacy is compromised. So then we have to look for definitive salvage therapy, and the backbone lies with daptomycin. And today, in the current era, levonadirfloxacin is also a choice, although the studies with levonadirfloxacin is far less in comparison with daptomycin. And why these two are particularly important choices, because they are both bactericidal, they have excellent bloodstream penetration, and the biofilm activity is overcome with high dose. So these are the three reasons why daptomycin and levonadirfloxacin are among the front runners of the antibiotics when they're used as a definitive salvage therapy. Then we add beta-lactam for synergy, and the preferred agents are ceftaroline, if ceftaroline is available. Right now it is not available in most of the institutes in our country, but at few places it is available where it is imported. So alternative to ceftaroline, one can also go for cefazolin, nafcillin, or piperacillin tazobactam. The main mechanistic explanation being that the beta-lactam alters the MRSA cell wall charge, and this increases the daptomycin binding, and that causes rapid kill of the organism. So this is also called the seesaw effect, similar to one which we have discussed during gram-negative infections. So when to use linezolid or teicoplanin instead? Now this has to be used only when it is a lung source. In lung source, that is when patient is having pneumonia, one should go for or linezolid or teicoplanin. if there is intolerable rise in the CPK after giving daptomycin. So that is another side effect. And third, mixed infection involving toxin suppression. So in those cases also, it is preferable to start with linezolid or tigoprevir. So this is not a preferred choice for bloodstream clearance because this is a bacteriostatic drug. And for clearing in the bloodstream, we always prefer CDL, drugs with CDL properties. However, there are certain evidences in favor of linezolid also, much to the fact that there are a lot of evidences against it. But among the good evidences are the one where linezolid versus vancomycin for the treatment of MRSA infections. So this has established linezolid at least as or as often as a superior, because or at least as a non-inferior to vancomycin, and its practical benefit of oral step down is also noteworthy. Another study by Moyes et al. In 2016 found that in MRSA BSI with high MIC to the tune of 1.5 to 2, early dapto seems to favor the outcome rather than pushing vancomycin. Also, Murray et al. Has shown in another study that if the MIC creeps is greater than 1, they support switching early to linezolid in rather than continuing with vancomycin. So the ICU management details, we have to monitor CK twice a weekly when the patient is on daptomycin, CBC weekly if the patient is on ceftaroline, and the duration should be for uncomplicated bacteremia, the minimum 2 weeks after the first negative culture, and for complicated ones, which includes deep focus, endocarditis, retained material, etc., this duration extends up to 4 to 6 weeks. So you have to remember that do not continue vancomycin and only hope for delay source control for drug escalation, because nothing will come out of nothing. So a quick summary, if you go by that, persistent bacteria for more than 72 hours is a sign to suggest that we might have to escalate the antimicrobials, stop vancomycin, start either daptomycin or levonarifloxacin plus piperacillin tazobactam, remove or replace any biliary drain or catheter, perform transesophageal echo plus CT abdomen pelvis, continue daily blood cultures until negative, and treat for more than or equal to 4 weeks if it is uncomplicated. Let us now move into the second case where a young adult is admitted with septic shock, hemoptysis with cavitary lung lesions, and panten-valentine leukocyte, that is the PVL, is positive. So unlike typical MRSA pneumonia, the PVL, that is the panten-valentine leukocyte toxin, converts this into a toxin-mediated pulmonary necrosis syndrome with rapid cavitation, alveolar hemorrhage, small vessel thrombosis, ARDS in hours, not days, and it has extremely high mortality which may vary from 30% to 60%. So patient deteriorates despite correct MRSA antibiotics unless toxin suppression is suspected. So if the patient is there, we will have to, sorry. So this Panton-Valentine leukocyte toxin is something which can worsen a patient overnight, that is with less than 24 hours. So this toxin mediated pulmonary necrosis syndrome can have rapid cavitation, alveolar hemorrhage, small vessel thrombosis, or ARDS in hours only if a patient doesn't have to wait for days, and has extremely high mortality. Almost 1 out of 2 or 1 out of 3 patients die because of this. Now, patients deteriorate despite correct MRSA antibiotics until toxin suppression is suspected. Now, if you can see here in A, these are the areas which can become nidus, particularly areas where the lung parenchyma is fibrosed or is not working, gaseous exchange not taking place, etc. So this is similarly another appearance where you can find some tree in bud appearance. And this is also, though not pathognomonic, but strongly suggestive of in the infection. So recognition in critical ICU pattern, there are certain red flags for PVL necrotizing MRSA pneumonia. That is, usually the patients are young and previously healthy. There is a flu-like illness which is preceding, often influenza A. Rapid progression occurs within 24 to 48 hours. There is hemoptysis. There is multilobar cavitation on the CT, leukopenia and not leukocytosis, and shock which is out of proportion to radiology. So the typical CT findings can be peripheral cavitations, patchy necrosis, pneumatocysts, bronchopleural fistula, small bilateral pleural effusions, and many more. So now, as we can see that these are the areas where what can be done to differentiate. As you can see that there are a lot of honeycomb appearances in B. Almost similar. So one has to also remember that leukopenia in a septic patient with lung cavitation is practically pathognomonic for PVL. The treatment strategy, always remember the toxin suppression has to be done first before anything else, and not just bacterial killing. So the primary drug of choice is linezolid 600 milligram IV 12 hourly, but the best toxin suppressing anti-MRSA drug and which gives excellent lung protection penetration, not inactivated by pulmonary surfactant, and it's bacteriostatic. But this is good because there's less lysis and there is less release of toxin. And the alternate, again, one can go for clindamycin if the patient is susceptible. So, as a treatment strategy, toxin suppression is the first. It is not just bacterial killing. The primary drug of choice is linezolid 600 milligram IV 12 hourly. Best toxin suppressing anti-MRSA drug, excellent tissue penetration, and is not inactivated by pulmonary surfactant. But the problem is that it is bacteriostatic, and but there is less lysis can also produce less toxin release. So that way bacteriostatic suits. Alternative drug is clindamycin if susceptible, but there are also a lot of problems. So one should not start vancomycin or daptomycin alone in PVL necrotizing pneumonia. So the quick summary would be the diagnosis is based upon hemoptysis with cavitation plus leukopenia in a young adult post-viral illness patient. Treatment is commenced with linezolid and clindamycin. Broad spectrum coverage should be given as appropriate. One can consider IVIG. Lung protection ventilation, yes, and one should absolutely avoid vancomycin monotherapy, daptomycin, and high tidal volumes. Coming to this third case is a post-transplant patient on steroids plus tacrolimus, but is having fever, cough, and hypoxia. The CT chest shows nodules along with cavitation. CT brain shows ring enhancing lesions, and the culture grows nocardia species. So why this is difficult to treat? Because there are certain key problems with nocardia. One, it is a slow-growing organism, so their diagnosis is often late. CNS seeding is common and it occurs silently. It requires months of therapy, not just weeks. And drug toxicities like bone marrow suppression, renal effects, can be easily observed and picked up, and they have interactions with immunosuppressants. So if we see multiple lung nodules in a transplant patient, we have to assume it as nocardia unless prevent otherwise. So the highest risk population in the ICU, this includes the solid organ transplant, where the risk is maximum with kidney, followed by lungs and followed by heart. In chronic steroids, TNF alpha inhibitors like infliximab, the roots of infection can be inhalation, leading to lung seeding, or hematogenous spread going to the brain and the skin. So every confirmed nocardia infection requires brain imaging. The clinical radiological pattern, which is classic for nocardia, includes random nodules, cavitating nodules, alveolar consolidation, and there is the tree in bud appearance, as it is very much evident. So in brain or CT or MRI, there are multiple ring enhancing lesions, often mistaken for tuberculosis, toxoplasmosis, fungal abscess, and metastatic cancer. So in ICU treatment strategy, the first line antibiotic is trimethoprim sulfamethoxazole in high dose. The doses should be 15 milligram per kg per day, and TMR component in 2 to 4 divided doses. So we can add combination agents in severe ICU infections like CNS involvement, disseminated disease, severe pulmonary cavitation, etc. So the common ICU combinations include trimethoprim sulfamethoxazole plus imipenem, trimethoprim sulfamethoxazole plus amikacin, then with ceftriaxone, and also with linezolid, where it has excellent CNS penetration. So the duration is critical because minimum 6 months and overall the period of therapy of 12 months is required. So the practical ICU decisions are the renal transplant, because trimethoprim sulfamethoxazole can cause AKI plus hyperkalemia. So monitor creatinine like potassium daily. Tacrolimus TMP SMX potentiates uh, So it potentiates tacrolimus toxicity. Dose adjusted tacrolimus and monitor the trough levels. Then there is CNS involvement also, where linezolid has been seen the best CNS penetrator of all nocardia drugs. If it is resistant or intolerant to the drugs, then can try for minocycline, moxifloxacin, ceftriaxone, or meropenem. Next, there should be some monitoring strategy which must be adopted, like the CBC, that is myelosuppression with trimethoprim sulfamethoxazole plus linezolid, one can use, or LFT. There can be, one has to choose because of risk of drug toxicity. And daily early electrolytes are normal. Trimethoprim sulfamethoxazole causes hyperkalemia sometimes, and monthly MRI brain should be done to confirm the radiological response. So the radiological lesions lag time response by weeks. So this should suffice. The steroid use. When is steroid helpful? When steroid is used as an adjunct in CNS edema or mass effect. A hypoxic respiratory failure with airway edema can lead to this adverse effect. And when harmful early indiscriminate use in septic patients should be avoided. Whenever there is chance of harm, one should avoid it. Advanced ICU considerations: when to call neurosurgery: large lesions with mass effect or midline shift, lack of response to antibiotics after 2 weeks, and if there is impending herniation. When to consider ECMO: it is rare but necrotizing nocardia pneumonia causing ultimately leading to the consideration of ECMO can be as high as 25 to 30%. Then IR guided aspiration, it has the best diagnostic yield in lung lesions. So have a quick look into the summary that do make MRI brain in all patients. It is necessary. We have to start high dose of trimethoprim sulfamethoxazole, add imipenem plus minus amikacin for severe disease, monitor potassium and creatinine daily, and this has to continue for at least 6 months. After that, one can repeat MRI and adjust the tacrolimus levels. Also check for disseminated involvement like skin, eye, bone, etc. Now, there are certain advanced ICU considerations. One has to remember that when to call neurosurgery: if there are large lesions with mass effect or midline shift, if there is lack of response to antibiotics after 2 weeks, and if there is impending herniation. When to consider ECMO: it is rare but necrotizing nocardia pneumonia causing ARDS. IR guided aspiration for best diagnostic yield on the lung lesions. So as I said, that one needs to be careful with the antibiotics, do MRI in all patients, and start with high dose of trimethoprim sulfamethoxazole. Thank you.